Senate Judiciary Committee will come to order. Today, the committee will hear from a range of experts about the cost of prescription drugs in America. Americans pay the highest prescription drug prices in the world, nearly 3 times what people in other developed countries pay for common medications. Take the cancer drug Keytruda, which has helped extend former President Jimmy Carter's life. It has an annual list price of more than $190,000 in the United States. In Germany, the exact same drug made by the same company cost $89,000. Jardiance, we can all visualize, excuse me. Senator Grassley.
I've had it too.
I'm with Grassley, sorry. Jardiance, you can all visualize the dancing lady in the yellow dress ad. A medicine used to treat type 2 diabetes retails for more than $700 in the United States, $150 in Canada, the exact same drug. Prices just keep going up. In 2022, drug manufacturers raised the prices of more than 1,200 medications by an average of 32%, 4 times the rate of inflation. The poster child for high drug prices is insulin. It was discovered 100 years ago by Canadian researchers who surrendered their patent rights for the sum total of $1 because they believe nobody should profit from this life-saving drug. The same thing is true of Jonas Salk and the vaccine that we used for polio. I remember that as a kid. He surrendered his patent rights to that drug too because it was so important. When Eli Lilly launched its insulin product, Humalog, in 1999, a vial cost a modest $21. Over the next 20 years, Eli Lilly raised the price of Humalog more than 24 times, with the cost ultimately reaching $330 for that same $21 vial. While the historic Inflation Reduction Act capped the price of insulin at $35 a month for Medicare, many patients are still paying inflated prices for a century-old drug. The pharmaceutical industry is going to tell you that high prescription drug prices are the cost of innovation and point to billions of dollars in research and development. In fact, a government agency financed by American taxpayers, the National Institutes of Health, plays an important role in innovation and research. NIH funding contributed to 99% of all new drugs approved by FDA between 2010 and 2019, with $187 billion in taxpayer-funded research, benefiting 354 of 356 new drugs. NIH is part of the solution. And too often, the prices charged by Big Pharma do not reflect a scientific advancement. Rather, they're the result of skilled lawyers manipulating the patent system and skirting our nation's competition laws. Take the blockbuster drug Humira, which AbbVie introduced in 2002. For more than 20 years, the company exploited intellectual property laws to build a thicket of 165 patents that allowed Humira to avoid competition. The result, $20.7 billion in revenue to AbbVie in 2021 alone, and over $200 billion in revenue over Humira's 20-plus years of exclusivity. These are massive, profitable drugs. I asked Blue Cross Blue Shield in Chicago, why are premiums going up so fast? The number one cause, these high-priced prescription drugs. Humira is not unique. A recent study found that the top 10 best-selling drugs in 2021 had a combined 1,429 patent applications filed, 72% of which were filed after the FDA approved the drug for sale. You know what's going on if you even have a beginner course in this business. The patent system is being manipulated and used by their attorneys to extend the patent life to avoid competition, generics, and bringing down the cost. These blockbuster drugs were covered by an average of 42 active patents. The FTC recently highlighted another page in Big Pharma's anti-competitive playbook when it challenged more than 400 patents as improperly listed in the FDA Orange Book. By listing these patents on inhalers, EpiPens, weight loss drugs, and more, their manufacturers delayed generic competition and padded profits. The committee has taken a leadership in addressing big pharma's abuses. Last year, we unanimously reported 5 bipartisan bills that address issues ranging from anti-competitive pay-for-delay agreements and sham citizen petition to patent thickets and product problems. This includes my bill with Senators Tillis, Coons, and Grassley to improve information sharing between the FDA and the U.S. Patent Office. This hearing will try to make clear that our work is not done. We have things to do. Ask the American people what they think about this issue. You know what you're going to hear. We see an average of 9 ads a day for drugs on television. You cannot escape them. God only knows where else the advertising is going. How many countries in the world allow direct-to-consumer advertising for drugs? 2, the United States and New Zealand. New Zealand, for God's sake. The only 2 countries in the world that allow this kind of advertising. Why do we do it? So that we can spell Xarelto and go to a doctor's office and say, I think I need a Xarelto to get well again, and to skip through fields of flyers. Many doctors, instead of taking the time to argue a reason for a generic drug or no drug, instead prescribe these drugs. And as a consequence, the cost of medicine and healthcare goes up and up and up, and the hard to justify profits continue. I will now, before I turn to my ranking member here, I want to acknowledge Senator Welch's interest in this hearing and this issue. When he first came to the committee, we sat down and talked about his subcommittee assignments, and he told me that this is one issue he wanted to focus on. So at some point in the hearing this morning, I'll be surrendering the gavel to him to continue this hearing. Thank you for being here, Senator. Senator Graham?
Thank you, Mr. Chairman. So we've acted in the past unanimously there seems to be 2 lanes here. Patent abuse, changing the patent in a small way to extend it, delaying generic entry into the market. Every day they can keep the patent going and keep the generic out of the drugstore is a good day for them. The other is countries like Canada, same drug, a lot lower in cost. There's 2 ways to deal with it, I guess. What I'd like to do is let countries know that most of these drugs are developed in the United States, and the drug company has the right to get its money back. If a foreign country is basically subsidizing a drug, putting a burden on the American consumer to have to pay a higher price, I think that's an unfair trade practice. So I'd like to go down that road. The bottom line, this is social media all over again. We pass all these bills, we have a common view of the problem, and nothing ever happens. So Wednesday, we're going to challenge the Senate to take up some of the social media reforms that we have reported out of this committee unanimously. I'd like to put this in that same bucket. I mean, we're about as diverse a collected group of people you could find in the Senate, and count me in. Count me in for like challenging the patent system. Count me in for trying to find ways to help the American consumer versus people in other countries. I'm very open-minded about stopping abuse. What I don't want to do is kill the goose that laid the golden egg. I don't want to create a system where we stop developing new drugs that enrich our lives. I think everybody who spends money, it's like drilling for oil. Sometimes you have a dry hole and you just, you write that off. The goal is to enhance medical science and deal with sheer greed, for lack of a better word. This has to stop. I don't mind you getting your money back. I want you to make a profit. But the idea of playing games with patents needs to stop. And I'm more open-minded about the advertising than I've ever been. And I see these ads. I don't know. Why do I need to know that? I mean, why can't I trust my doctor to if a generic works, it works? So let's work together. And when we pass something out of the committee, let's go to the floor and challenge the Senate to let it go. So it's a good hearing. I'm glad you're doing it.
Thanks. Today we're going to welcome a consensus panel of 5 witnesses who I'll introduce. Artie Rye is the Elvin Laddie Distinguished Professor of Law and co-director of Center for Innovation at Duke. She is an internationally recognized expert in intellectual property law, innovation policy, administrative law, and health law. Adam Mossoff is a professor of law at Antonin Scalia Law School, where his research focuses on the theoretical justification for and historical protection of patents and other intellectual property rights as private property rights secured to inventors and creators. Dr. Will Feldman is a pulmonologist, intensivist, and health services researcher at Harvard Medical School and Brigham and Women's Hospital. His research focuses on drug pricing, FDA regulation, pharmaceutical policy, and COPD outcomes. Jocelyn Ulrich is the Vice President of Policy and Research at Pharma Research Manufacturers of America. At Pharma, she leads the team responsible for policy analysis and research. David Mitchell, President and founder of Patients for Affordable Drugs, is a patient advocacy organization focused on making prescription drug prices affordable for every person. He is a patient with incurable but treatable blood cancer. He depends on drugs costing hundreds of thousands of dollars a year. So I'd ask all the witnesses to please stand first for the administration of the oath. Would you raise your right hand? Do you affirm the testimony you're about to give before this subcommittee will be truth and the whole truth, nothing but the truth? So you got it. Let the record reflect that the witnesses did better than the administrator of the oath and answered in the affirmative. So we'll start with Professor Rye.
Thank you, Chair Durbin, Ranking Member Graham, and members of the Senate Judiciary Committee for the invitation to testify. I've worked on drug competition issues for many decades. My research is funded by nonprofit foundations and government agencies only. Today, I will discuss three aspects of the challenge, all of which relate to patents of dubious validity. Fortunately, dubious validity can be addressed through surgical responses. We need, first, greater coordination between the PTO and the FDA. Second, limits on patent assertion when the patent is an obvious variant of a patent that has already been found obvious. And third, to ensure the continued vitality of the Patent Trial and Appeals Board. Let's begin with greater interagency coordination. Many of you have rightly been concerned about applicant statements to the FDA that are highly relevant to patent validity, but that are nonetheless never brought to the attention of the PTO. These submissions can take the form of comments made or statements made to the FDA that are flatly inconsistent with those made to the PTO. That was the scenario in Belcher versus Hospira, a 2021 case in which the behavior was so egregious that the Federal Circuit found a Belcher executive guilty of inequitable conduct. But my research has shown that the problem of incomplete information flow to the PTO is much more systemic. For example, manufacturing process patents represent by far the largest category of patents asserted against would-be biosimilar competitors. Nicholson Price and I have shown that over 70% of these assertions involves patents with a priority filing date of more than 1 year after the originator product was marketed. For such late-filed patents, long-standing Supreme Court case law makes it clear that patent applicants should inform the PTO of commercial use that is related to or identical to the process that they seek to patent. That is true even if, or perhaps especially if, the use is secret. The reason is straightforward. A firm that relies on secrecy for commercial advantage should not subsequently be able to extend its exclusivity further by securing a patent. The patent system is supposed to be about information that is disclosed, not kept secret. Unfortunately, applicants do not routinely disclose prior commercial use to the PTO. However, the information is known to the FDA, and therefore it is part of the executive branch's set of information. It is simply siloed. We all know about agency siloing. One reason may be agencies' legitimate awareness of the need to maintain trade secrecy. This is very legitimate, but I think that the congressional push led by Senator Durbin is exactly what is needed to overcome agency reluctance. The Senate's Patent Agency Interagency Coordination and Improvement Act, sponsored by Chair Durbin, recognizes that information flow from the FDA to the PTO is perfectly consistent with trade secrecy. The PTO can also help the FDA. Recently, the FTC has been active in calling out patents that are improperly listed on the Orange Book. But the FTC has to do its work very late in the day. George Contreras and I have argued that the PTO could nip the problem in the bud by helping FDA ensure that irrelevant patents are never listed. Another problem relates to terminal disclaimers filed by patent applicants to overcome examination rejections for obviousness over a prior patent they hold. Simply put, a disclaimer filing shows that the patent applicant lacks confidence that its application is non-obvious relative to its prior patent. Terminal disclaimers, are a big deal. A recent study by Dr. William and Feldman and his co-authors found that 48% of patents asserted against biosimilar competitors contain terminal disclosures. The PTO has recently proposed a carefully crafted rule to address this issue. However, the agency's rulemaking authority in this area might be overly narrow, and I believe a very useful revision to the patent statute would calibrate PTO's rulemaking authority in this area and harmonize it with that given to the PTO over the PTAB. Speaking of the PTAB, there the answer is simple. Keep up the good work. My data show that the PTAB is doing an excellent job and it does not need to be interfered with. Thank you, and I look forward to your questions.
Thanks, Professor Wright. Professor Mousoff.
Thank you, Chair Durbin, Ranking Member Graham, and members of the committee. Thank you for this opportunity to speak with you today about how policy-driven arguments concerning patents have sown confusion and impeded evidence-based policymaking on drug prices. The causes of drug prices are complex and multidimensional, if only because the U.S. healthcare system is incredibly complex itself. Yet despite this, professors and policy activists have reduced this legal, institutional, and scientific complexity to a single cause: patents. They blame patents as the primary, if not the sole cause of drug prices today. This is profoundly mistaken. It's impossible to comment on the incredible number of legal and policy activities in all three branches of government today affecting drug patents. And so for the sake of brevity, I will focus on the misinterpretation and misuse of two federal laws by those seeking to impose price controls on innovative drugs and other healthcare inventions in a misguided effort to lower drug prices. The first law is the Bayh-Dole Act, and the second is a law known as Section 1498. Now, neither the Bayh-Dole Act nor Section 1498 are price control laws. This is clear in their text, function, and in their past interpretation by courts and agencies. Congress enacted the Bayh-Dole Act in 1980 to promote commercialization of inventions that result from some upstream federal funding. The law reaffirmed the fundamental principle in American patent law: all inventors should be secured in the fruits of their productive labors with a property right, a patent. Now, before the Bayh-Dole Act, the federal government actually ignored this fundamental principle and instead claimed ownership in inventions resulting from federal funding. It offered non-exclusive licenses to any and all comers. As a result, there was no commercial development of these inventions. The Bayh-Dole Act importantly changed that policy. It's reaffirmed that inventors can obtain patents and then assign or license them to marketplace actors regardless of who funds and how much funding is received in the initial research. The result has been an explosion in new products and services, from new cancer drugs to the Google search algorithm to the Honeycrisp apple and so many others. Today, the Biden administration proposes to turn the Bayh-Dole Act on its head. A proposed new regulatory guideline twists the Bayh-Dole Act into a price control law in which funding agencies can license any resulting patent to a private company simply to drive down prices. This returns the U.S. back to the pre-Bayh-Dole era of de facto government ownership and non-exclusive licensing. But the Bayh-Dole Act is not a price control law. It never states that price is a precondition for an inventor who obtains and then licenses or assigns a patented invention. In fact, the goal of the Bayh-Dole Act is commercialization as such, not low prices. Now, this is really important because Congress knows how to enact price control laws when it wishes to do so, and it has done so many times. One of my favorite examples, the Emergency Price Control Act of 1942, very clear in what that law does. That is not the Bayh-Dole Act. In a short-sighted effort to drive down drug prices, these new regulatory guidelines will kill this golden goose of innovation and economic growth. The second law that is misconstrued today by those seeking to impose price controls on drug patents is Section 1498. Now, this doesn't have a name because it's a century-old law that secures to patent owners the protections of the Takings Clause of the Fifth Amendment. It ensures a court can hear a claim for compensation when an official or government contractor uses a patent without authorization for a government use, such as the military or the post office. Today, price control advocates seek to turn this law on its head as well. Now, in its text and function, Section 1498 secures the rights of patent owners against unauthorized uses of their property by the government, guaranteeing the same compensation as all other property owners. Now some seek to turn Section 1498 into an unprecedented compulsory licensing regime in which the government promotes private companies to violate patent rights. Again, a law is being twisted to achieve short-sighted policy goals of lowering drug prices. Today, the U.S. is a global leader in healthcare innovation. The biotech revolution began in the United States in the 1980s. More than 50% of all new drugs are invented in the United States to this very day. Diseases like cancer, diabetes, hepatitis are no longer death sentences, but are now curable or at least manageable conditions. This was all made possible by the U.S. securing reliable and effective property rights and the fruits of the labors of the innovators working in the biopharmaceutical sector, securing patents. Countless lives have been saved, lifespans increased, and quality of daily life enhanced for everyone in the world. The patent system and laws like the Bayh-Dole Act and Section 1498 made this possible. Thank you, and I look forward to your questions.
Thank you, Professor Mousoff. Dr. Feldman, please.
Chair Durbin, Ranking Member Graham, and members of the committee, thank you for the opportunity to testify today. I became interested in pharmaceutical pricing during my medical training when I observed firsthand how patients were often unable to afford their medications, leading to decreased adherence and worse health outcomes. Much of my research today focuses on how pharmaceutical firms use patent thickets and product hops to delay generic competition and keep prices high. The U.S. federal government rewards pharmaceutical innovation by granting time-limited monopolies to sell prescription drugs free from generic competition. And the key here is time-limited. Once patent protection ends, generic firms can enter the market. Such competition is by far the most important tool for lowering prescription drug prices in the U.S. Unfortunately, many brand name firms now engage in strategies designed to game the system and extend periods of market exclusivity to the detriment of patients and payers. Consider inhalers for asthma and COPD. Millions of Americans rely on these products to help them breathe. Last year, AstraZeneca brought a product to the market called AirSupra. This product contains albuterol, first approved in 1981, and budesonide, first approved in 1994. AirSupra has patents lasting into the 2030s, and the current list price is over $500. Even with substantial rebates, we're still talking about a couple of $100s for a product with active ingredients that were approved 30 to 40 years ago. And there is no hard clinical evidence to suggest that this product is any better than another AstraZeneca inhaler that has been on the market for 2 decades. By no means is this criticism intended to single out one company. All of the other 3 major brand name inhaler manufacturers, GSK, Boehringer Ingelheim, and Teva, engage in similarly problematic strategies. For example, we have found in our research that more than half of all patents on inhalers are on the delivery devices of these products. And these patents have extended market exclusivity, these device patents, by a median of 5 years. 77% of these device patents fail to even mention, much less claim, the active pharmaceutical compounds in the products. According to recent FTC action, these patents should never have been listed in the Orange Book in the first place. Yet these tactics have been lucrative for inhaler manufacturers. Of the $178 billion that inhaler manufacturers earned on these products just in the US from 2000 to 2021, more than $110 billion accrued after patents on the active ingredients had expired. That's 68% of revenue after patents on the active ingredients had expired. I applaud the FTC's efforts to crack down on improperly listed patents, and also those of the Senate Help Committee, which launched an investigation into inhaler manufacturers earlier this year. This work is extremely important. But inhalers are just one example of abusive patenting practices that have become rampant across the pharmaceutical system, and we need comprehensive reform. The Senate Judiciary Committee has recently moved 4 bipartisan bills out of committee that, if enacted into law, could facilitate more timely generic competition. These bills focus on establishing better communication between the USPTO and FDA, limiting product hops, punishing brand name firms for baseless citizens' petitions, and preventing pay-for-delay settlements. I strongly support these bipartisan efforts. I would also urge you to consider 5 additional measures to further advance the important work you all are doing to facilitate more timely generic competition. First, grant the FDA the authority and resources to evaluate all patents submitted for listing in the Orange Book to determine eligibility for inclusion. Second, require that all patents submitted to the FDA for listing in the Orange Book are also concurrently submitted to the USPTO for re-examination. Third, limit the number of patents that brand name manufacturers can assert to 1 patent per family when suing for infringement. Fourth, grant the FDA more authority to approve generic drug device combinations that differ slightly from brand name reference products while still containing the same active ingredients, and require the FDA to ensure that post-marketing surveillance studies are conducted to confirm similar outcomes between those receiving generic and brand name versions. And finally, I would encourage Congress to increase the 180-day exclusivity periods for the first generic firms to file paragraph 4 certifications on complex products like drug device combinations, and decrease the automatic 30-month stays awarded to brand name firms that sue for infringement. We should strive for a pharmaceutical system that rewards meaningful therapeutic breakthroughs, cures for hepatitis C, new mRNA vaccines, not small modifications to the plastic components of delivery devices or new tweaks to molecules that perform no better than existing therapies. Thank you for your time.
Thanks, Doctor. Mr. Ulrich.
Chairman Durbin, Ranking Member Graham, and members of the committee, thank you for inviting me to participate in today's hearing. Pharma appreciates the opportunity to discuss ways to improve the affordability and accessibility of life-saving medicines for patients. It is no accident that the United States leads the world in the development of treatments and cures for patients. This is the direct result of our carefully designed ecosystem, built over many years through smart public policies that encourage risk-taking and collaboration. At the core of this ecosystem are strong and reliable intellectual property protections that give companies the certainty they need to make the long-term investments required to bring new medicines to patients, as well as to improve them for additional patient benefit. In fact, the biopharmaceutical sector is one of the most research-intensive industries in the United States, spending more than $100 billion every year researching and developing new medicines for patients. This spending far outpaces the NIH's budget for drug R&D year over year. Our members are committed to tackling the hardest, most difficult to treat diseases, and they make significant investments knowing that fewer than 12% of potential medicines that make it into clinical trials will eventually be FDA-approved medicines. By any measure, America's IP framework has been a resounding success. Despite the long odds, biopharmaceutical companies have launched more than 750 drugs since 2000, resulting in significant progress against some of the most costly and challenging diseases. For example, new CAR-T therapies are curing children with advanced leukemia by training cells to fight the cancer. And as a result, since peaking in the early 1990s, cancer death rates have declined by 33%. Due to highly effective antiretroviral therapy, the HIV/AIDS death rate has declined by 91%, allowing HIV patients to live close to normal lifespans. And patients with sickle cell disease can be treated with a genome-edited cell therapy that has the potential of a functional cure for their disease. These advances not only improve patient lives, but they help avoid other more expensive healthcare costs. For example, between 1999 and 2012, there was a significant reduction in Medicare spending growth for cardiovascular disease, and 1/4 of which was due to the greater use of cardiovascular medicines. Importantly, our IP system not only incentivizes the development of new medicines, but it spurs competition that lowers healthcare costs. First, there is robust competition from other brand manufacturers. No company has a monopoly on treating a disease. Companies compete to develop the most effective treatment options for patients. For example, within a year of the first breakthrough treatment for hepatitis C, the availability of multiple competitors reduced the average price or the net cost of these medicines by nearly 80%. Data also show discounts and rebates are already lowering the net costs of treatment with GLP-1s by as much as 79%, with more competition on the way. And eventually, medicines face competition from generics and biosimilars, which drives down costs even more. On average, a drug is on the market only 13 years before facing competition from generic versions, much shorter than the patent life of 20 years, and typically drive down costs as much as 80%. This is what makes the marketplace for medicines unique. Similar cost containment mechanisms do not exist for any other part of the healthcare system. But there are real challenges for getting more affordable options to patients. Insurance companies and their pharmacy benefit managers determine what medicines are covered, what patients pay out of pocket, and what hoops they have to jump through to access the medicines their doctor prescribed. Today, 3 large PBMs now comprise nearly 80% of the market, and each is vertically integrated with health insurers, specialty and mail-order pharmacies, and provider groups to form large healthcare conglomerates, and they are significantly impacting whether patients are able to benefit from biopharmaceutical innovation. PBMs often stand in the way of patient access to lower-priced versions of medicines, routinely denying or limiting coverage. And with growing scrutiny over rebates, PBMs have leveraged their vertical integration to create new sources of revenue. PBMs are also choosing to tie patient cost sharing to the list prices rather than the discounted prices that they themselves pay. You'll likely hear today that the market is competitive and that abuses of the IP system and patents are the real problem. Instead, Congress should be focused on advancing policies where competition could be advanced without undermining the very foundation of the industry's ability to innovate. This includes addressing the misaligned incentives in the PBM market. Thank you for the opportunity to testify, and we look forward to working in a constructive way to ensure patient access to the medicines they need.
Thanks, Ms. Ulrich. Mr. Mitchell?
Chairman Dermott, Ranking Member Graham, committee members, thank you for inviting me. I'm David Mitchell. I'm the founder of Patients for Affordable Drugs. More importantly, I have an incurable blood cancer called multiple myeloma. Most patients with my diagnosis will die of it, but right now, prescription drugs are keeping me alive. My doctors have me on a 4-drug combination with a list price of more than $1 million a year. Just one of my oral drugs, a drug called Pomalyst, is priced at more than $22,000 for 21 capsules in this little bottle that I have to buy 13 times a year. And because Medicare beneficiaries like me pay our costs based on list price, I spent more than $16,500 out of pocket last year just for Pomalyst. The Inflation Reduction Act changed that. This year, an out-of-pocket spending limit began to take effect, and my cost is $3,326. Next year, the limit will drop to $2,000, and no one on Part D will pay more than that. For me and other patients like me who have to take very expensive drugs to stay alive, it is life-changing. The drugs are keeping my cancer at bay, but their efficacy is waning, and eventually I will need a new treatment and one after that. So I care deeply about innovation and new drug development. Without it, I'm going to die sooner than I hope to. That's why this hearing is so important. Our patent system was put in place to incentivize and reward risk and investment in new treatments that can save my lives and the lives of others. But too often, drug companies are instead investing in a legal strategy using patents, not to reward innovation, but to block competition. In one recent 10-year period, 74% of new drug patents were issued for drugs already on the market. Of the roughly 100 best-selling drugs, nearly 80% obtained an additional patent to extend their monopoly. Partly as a result, we pay more than 4 times what other wealthy nations pay for the exact same brand name drugs. 30% of Americans say they struggle to afford their medications. Let's look at another drug I take to prevent blood clots and stroke, Eliquis. In 2023, it was the most expensive drug for Medicare at $12.6 billion. Its maker, Bristol Myers Squibb, has applied for 48 patents and been granted 27, blocking competition in this country. The list price for a 30-day supply in the U.S. is about $600. In Canada, where there is a generic on the market, the price is about $75. We need to restore balance to our broken drug patent system so it does incentivize and reward true innovation instead of being used to block competition. The FTC is moving on this problem, as the chairman pointed out, challenging more than 300 junk patents, as many as 400, that are listed in the Orange Book, and Congress can act to help now. Bipartisan bills to address the principal abuses of our patent system by drug companies have cleared committee and are ready for passage in the Senate. They deal with pay for delay, patent thicketing, and product hopping. There are 2 more bills to improve FDA practices that will speed generics to market. They stop the abuse of citizen petitions and allow the FDA to share important information with generic manufacturers to help them get to market more quickly. Now, while the headwaters of our drug price problems are the list prices set by drug companies, as Ms. Ulrich pointed out, there are other reforms needed downstream in the supply chain. Pharmacy benefit managers are black boxes that cut secret, often mutually beneficial deals with drug companies, and none of it is transparent. We need to increase transparency and curb anti-competitive practices by PBMs. There are bipartisan bills in both the House and Senate to accomplish these goals. I am here today to ask you all to pass all of these bills, which will allow competition and market forces to lower drug prices for millions of Americans, regardless of how they pay for their drugs. These bills also save money for taxpayers, and we're pushing, along with dozens of allies, for inclusion in any year-end health care package that may be negotiated. And in a city riven by political division, these bills are thoroughly and completely bipartisan. Together, you can pass them. Please don't let this opportunity to help millions of Americans slip away. I look forward to answering your questions. Thank you.
Mr. Mitchell, thank you very much. There'll be rounds of questions from the members, 5 minutes each. I'll start and then turn the gavel over to Senator Welch. Dr. Feldman, since you're the only medical doctor on the panel, I'm going to ask you an obvious question. The legal system in America basically says that in order to have a prescription drug, you need a doctor to write a prescription. So a doctor's judgment is involved in that administration of that very basic principle. So my question to you is this. We know the pharmaceutical industry spends $6 billion a year, the size of the entire FDA budget, to fill the airwaves with brand name drug ads. That way patients can not only pronounce Xarelto, maybe even spell it, but they can also tell their doctors that's the blood thinner they want. So the pharmaceutical industry must believe that that's good enough to inform the consumer of the benefits of this drug and some of the dangers of the drug at one time, but to basically get them to the point where they go to the doctor and say, I want Xarelto. Then the doctor in our system has to make a professional judgment. Is that the right drug for this patient? Is there a better drug? Clearly, pharma believes that the consumer suggestion is going to be pretty powerful in this equation. So I don't want to say this in a negative fashion, but I'm going to. Are doctors complicit with pharma in prescribing overpriced drugs because they don't have enough time or inclination to debate the issue?
Thank you. You know, I think doctors clearly, as you said, pharmaceutical companies are spending this money on advertising because they think it works and because to some extent it does work. I do think that I know some doctors receive money from pharmaceutical companies for prescribing certain types of medications. And so I do worry that some physicians are complicit in this to an extent.
Well, they're gatekeepers in this process, and if they aren't there, I don't know who would police the ranks in terms of that. Ms. Ulrich, when you hear over and over and over and over again the fact that a basic drug being sold to Americans is at a price that is dramatically higher than you're selling the same drug in your industry in other countries, do you just shrug it off and say, that's just the luck of the draw? Or is it the fact that Americans are being asked to pay for the innovation and the cost and the profits, whereas other countries basically put their foot down and say, this is greed and we're going to stop you?
Well, thank you, Senator Durbin, for that question. I first would point out that when we're looking at comparisons of U.S. spending, medicines are about the same share of overall healthcare spending as European countries. So it is, when you're looking at the actual relative contribution of spending on medicines, it's similar. In addition, I would point out that comparisons are often looking at list prices, and as I spoke about in my testimony, we know that there are significant amounts of rebates being paid to PBMs and others in the supply chain that are not accounted for when we're doing those cross-country comparisons.
Well, let me say this about your suggestion. If I put one hand over a flame on the stove and the other hand in the freezer, on the average, I should be just fine. But life doesn't work that way. And say, on the average, other countries are just about as expensive as the United States. The list prices are dramatically different, 100% different. Why would you do that to the American consumers when you're American companies?
Well, I would also point out that Americans get access to those medicines much faster than those countries as well. 85% of globally approved new medicines are available to patients in the US versus about 40% in the EU countries. And cancer medications, European patients are getting access 2 years later on average. So patients are benefiting from that innovation as well.
Mr. Mitchell, what do you think?
Well, I think that drug companies file first here because we are the largest market in the world with the highest prices in the world. And they come here because the FDA is pretty easy to work with, and it's a high-quality drug approval agency. And so they come here, they apply first to get access to the market, but also they can take a lot of their filing work and take it abroad. It's interesting to note, because the IRA was raised earlier, that even after the IRA is fully implemented, we will still be the largest market in the world with the highest prices in the world, and they are still going to file first here. And it's because it's in their business interest to do so.
Senator Graham?
Chairman, so, Mr. Mossoff, you said 50% of all the new drugs are made in America, is that right, or developed here?
Yes, it's actually more than 50%.
You agree with that, Ms. Ulrich? Okay. Why is that?
So, in very much, it's a great question.
Are we smarter, or what's the deal?
And very much, I believe it has to do with the patent system. In the sense that the United States innovatively took the position, starting from the very beginning of the country, that they would secure next generation technologies and they would protect them as property rights.
So patents are a good thing?
Patents are a driver of economic growth, of new innovation, yes.
Okay, I agree with that. Now, is patent abuse a problem when it comes to drugs?
So there's a lot of rhetoric about whether their abuse exists.
I'm not talking about the words, the actions.
Yes. So it's very difficult to sometimes find actual evidence. So for instance, you see evidence of abuse. Are there some cases? Yes, because in every legal system in every area of life, there's going to be some bad actor.
So, Dr. Feldman, do you believe there's gaming of the patent system by pharmaceutical companies?
I think there's no question.
See, I'm with you on this one.
You look at I don't think it's sort of finding a needle in a haystack. Everywhere we look, every study we do, we find gaming. We look at drug device combinations. I talked about inhalers. We see the same thing on GLP-1 receptor agonists like Ozempic.
Yeah,
and
so
Wegovy.
I'm with you on that. So I want to keep the patent system in place because it's good. I just think the problem is real in terms of patent abuse, the games that people play, Senator Grassley's, pay to delay, that kind of stuff. So count me in on trying to fix that without killing the golden, the egg laid by the goose. Ms. Ulrich, you talked about PBMs. What percentage of cost do you think could be attributed to them?
I'm sorry, I don't have a number, but I can tell you that, with 80% being controlled by 3 in the vertically integrated entities, that there's extreme market pressure being controlled by those 3 entities.
Okay, so that'd be a good place for us to look to create some competition, right?
I agree.
Do you agree that there's patent abuse in your industry?
Pharma is not in support of anti-competitive behaviors.
Well, that's not the question. Do you agree there's patent abuse in your industry?
Well, I believe that there are controls in place to handle that when there is.
So you don't think there's a problem?
I think that the courts and FTC has the
So
authority to deal with that.
You don't think there's a problem with pharmaceutical companies playing games with patents to keep generics out of the market?
I think that the system has the correct checks and balances in place.
So you think it's working?
I think it's working.
Yeah, well, I don't. Mr. Mitchell, you're on the receiving end of all this. One, I hope the next drug comes along quickly because there are a lot of people like you in different areas of our society depending on Ms. Ulrich. I mean, I'm trying to say new drugs are good, gaming the system bad, PBMs need to be better controlled. Is that a good summary?
I'd say so.
Okay, now let's go to foreign countries. If a drug is a lot cheaper in a foreign country because of government action in that country to subsidize the drug, would you consider that an unfair trade practice, Professor Mossoff?
Potentially, yes. I mean, there's one of the problems with the cost of high drugs in this country is that this is the last country in the world, as far as I'm aware, that drug manufacturers and drug innovators can sell the price in the marketplace at a price that they would seek to sell it at. All other systems have single-payer systems.
Professor, do you consider that a potential unfair trade practice?
Thank you for the question. It could be, yes. I mean, I do think that it is the case. I'm not an international trade expert, but it is the case that.
So here's what I'd like to do as a committee here. Focus on the fact that some countries actually do lower the prices through government action that we prohibit here. For all the reasons you said, that makes our consumers have to absorb more of the R&D. That, to me, needs to be part of the conversation. To me, that is an unfair trade practice. Does that make sense to you, Mr. Mitchell?
Respectfully, Senator, I disagree. I don't think their prices are too low. I think our prices are too high. And the reason their prices are low is one reason is that we're the only nation in the world that permits drug companies to dictate prices to its citizens. The only nation on the planet. Every other country negotiates. We only began to negotiate this year, and we will negotiate over a total of 60 drugs out of about 4,000. But we should do more negotiating.
Yeah, I understand to a point. The question is what role of the government here? And I'll let you go. I wish you well. What role should the government play in all this is a very important decision to make. And when a country is having governmental policies that make our consumers pay more for the R&D we all need, I'm going to go after those countries. Thank you.
Senator Whitehouse.
Thank you, Chairman Welch. Good to be with all of you. I know we've talked a fair amount about drug ads. Obviously, like everybody else, I see a lot of them on my television. As best I can tell, they provide the public no health care value whatsoever. They provide sales and marketing value for the companies that are paying for the ads. And as best I can tell, what the marketing strategy is to convince everybody that all these drugs are a cure for loneliness. I don't know if you've noticed, but the person always starts off alone, and then they tell you about the drug, and then they're with friends, or they're, instead of alone on the dock, out in the lake with their family in the canoe. And the mental communication, the message is, this drug will make you less alone and lonely. And then, of course, you don't even listen to all the horrible things that the drug is going to do to you in the rapid, fast-paced, legally driven script at the end. It's a very peculiar piece of propaganda art, and I would love to understand more about how it's made to work. But the ads that I really want to talk about are other ads, and that has to do with Big Pharma's role funding dark money political pressure and ads. Pharmaceutical and health product companies put over $372 million into lobbying Congress and federal agencies in 2022, $1/3 of $1 billion. They deployed over 1,600 lobbyists, 3 times the number of members of Congress. Now, it's hard to keep track of dark money spending compared to lobbying because that's the whole purpose of using dark money funding channels. But an investigation by Issue 1 showed pharma contributed more than $34.5 million to the House GOP-aligned dark money group American Action Network since 2010. $35 million is enough to get the attention of House Republican leadership, I think. In 2022 alone, pharma gave a record $7.5 million to American Action Network, which spent millions on advertising in 2022 opposing our drug pricing reform efforts, and specifically the ones that made it into the IRA. Pharma donates to the Koch and Trump-affiliated dark money organizations Americans for Prosperity, Americans for Tax Reform, and America First Policies. A summary by the Washington Post in 2021 was pretty good. Congress members who supported legislation to curb the cost of prescription drugs faced, and I'm quoting here, massive months-long advertising, lobbying, and political donation blitz undertaken by the pharmaceutical industry and its allies to kill a Democratic proposal to lower the cost of prescription drugs by empowering the federal government to negotiate their prices. And obviously, particularly the political donation blitz and the advertising blitz have a lot to do with putting those political ads up on TV, which I think are disconcerting to folks in America, because when it's your TV and there's a message coming into you across your TV, and it's paid for by a group with a name like Americans for Peace and Puppies and Prosperity, and you know perfectly well that there is no such group that provides any real service or any real product. They're just there to mask who's really trying to communicate with you. It's creepy as hell. And I think we need to fix that, and I would like to encourage all of you to do whatever you can to encourage the pharmaceutical industry to at least be transparent in its spending. Don't use Americans for Prosperity or some of these other front groups as intermediaries. If you really think this opinion that you're offering into people's living rooms is worth it, own it. And I'll leave it at that. Actually, let me ask Mr. Mitchell, what do you think are the sort of red flags that we should be looking at where anti-competitive use of the patent system is signaled as opposed to pro-innovation use of the patent system?
Well, anytime you have a drug like Humira that, as the chairman pointed out in his opening remarks, had 165 patents on it, and I remember the day Senator Cornyn spoke to the chairman of Humira in a hearing and couldn't get a straight answer from him on how many patents there were on Humira. Those patents, which began to expire in Europe in 2018, led to prices in Europe that were 15% of the prices that we paid in this country until Humira competition finally hit the market last year. So look for the number of patents, look at what's happening abroad. Did they give away a little bit of the market in Europe in order to protect their market here from competitors? There are signs to look for.
Thank you very much.
If you heard what Mr. Mitchell said, you're going to hear it again. So I have this question about some bills that we've already passed out of this committee that I think lead to anti-competitive practices in prescription drugs, as well as the availability of lower price generic alternatives. We focus on pay for delay deals, citizen petitions abuse, product hopping and evergreening, and unfair PBM practices. And so these bills kind of come out with these names in this committee: Prescription Pricing for the People Act, the Preserve Access to Affordable Generics and Biosimilar Act, Stop Stalling Act, the Affordable Prescription for Patients Act, and the Interagency Patent Coordination and Improvement Act. And it's frustrating that these bills move and become law. And why they have not, I don't know. I hope that we can break the logjam for the benefits. And Mr. Mitchell, you made that very clear. So I was going to ask you as one of three people here, so I'm going to focus on Professor Rye and Dr. Feldman. Do you believe that these bills that I've mentioned will help promote competition and lower drug costs?
Thank you for the question. Yes, I do believe they will. I don't know that I would agree with the particulars of every single bill, but I've already endorsed heartily the Interagency Coordination Act, and I believe that the bills for product hopping in particular could be very useful as well. There's also a bill on patent thickets that I think could prove very useful. So yes, overall, absolutely.
I agree. I think every bill that we are talking about here today, all of these bipartisan bills, would help address the problem. To me, there is no silver bullet. I wish there was one solution that could solve all of our problems, but I really think the work this committee is doing around all of these issues, around better communication with the USPTO and FDA, around citizen petitions, pay for delay settlements, we really have to be going after every single issue to make incremental progress on what I think is a really real problem for our healthcare system.
Yeah. Ms. Ulrich, you made very clear in your answer to a question that the three biggest PBMs have 80% of the market, so I don't need to ask you to explain that further, but I'd like to zero in on a bill that Senator Cantwell and I have focused, called the Pharmacy Benefit Managers Transparency Act, to prevent unfair anti-competitive practices by PBMs and to bring about greater transparency. Specifically, our bill would prohibit deceptive pricing schemes and arbitrary clawbacks of payments made to pharmacies. The bill would also require PBMs to report to the FTC how much money that they make through spread pricing and pharmacy fees. Do you believe that this bill would help address competition concerns and lower price of drugs for patients?
Yes, thank you, Senator Grassley. I think we support the principles of that bill, but I would defer to my other colleagues who are more engaged on PBM policy more directly to answer you fully, and we would be happy to engage with you further on that. Okay,
thank you very much. I would go to Ms. Ulrich and Professor Mossoff. I'd like you to answer questions about the federal government investing $50 billion in healthcare research in this fiscal year alone. On top of that, we know the pharmaceutical industry invests 80 to 90 annually on research and development. Universities, pharmaceutical companies, biotech startups, small inventors, and other stakeholders are all engaged in innovation to find cures and produce life-saving drugs. So, Professor Mossoff, how do we build on this work so that we can find the next miracle drug without breaking patients' pocketbooks? What kind of incentives spur investment in R&D?
I think that as a general principle, we should continue to retain the system that has made possible the biotech revolution and all of these incredible new drug treatments, which is reliable and effective patent rights that are secured to the innovators that they can deploy in the marketplace. The data that I have on the funding shows that at least as of 2018, you have private R&D funding of around $129 billion, and which, as Ms. Ulrich had said, dwarfs the the $40 billion or so by NIH. So it's not true that what many people believe, that the government funds all drug development or all drug discoveries. In fact, one study done in 2021 of just the grants by the NIH in the year 2000, there were 23,230 NIH grants in the year 2000, and those were linked to only 18 FDA-approved medicines by 2020. So what you have is a continuing process in which the NIH funds very far upstream initial research, right? The basic research. And then once the university researchers figure out that this is something that might be important, they get a patent. The university licenses it to a biotech company, or they create a startup and get venture capital financing, and that's what accounts for the $2.6 billion on average that goes into drug development, ultimately that leads to an FDA-approved therapeutic treatment in the marketplace. And we should continue to ensure that that can happen by ensuring that the Bayh-Dole Act is not changed and that it continues to function in the way that it has functioned very successfully in the past 30 or 40 years in this incredible R&D pipeline that has been developed. As I said, rooted in this system of property rights and to innovators that we have had in this country for 200 years.
I'll submit questions for answer in writing. Thank you.
Thank you.
Senator Hirono.
Thank you, Mr. Chairman. Thank you all for testifying. I know that every time we compare pharmaceutical prices, we are told that Europeans pay far, far less. But I do acknowledge, as you said, Professor Mossoff, that our healthcare system is very complicated. You're the only person on the panel who happened to mention that other nations have single-payer systems. In our country, adding to the cost of healthcare is depending on how you get injured and what system is kicking in to take care of you. We have the VA, the largest healthcare program in the country. We have private insurance. We have Medicare. We have Medicaid. In Hawaii, we depending on if you get hurt in an auto injury, then that's another system. So I think that, if you, there is no single bullet. And for us to just, I realize that the patent system abuses is part of the problem, but for us to sit here and just point our fingers at the patent system is not going to resolve in the kind of non-silver bullet that we also acknowledge. And in fact, Professor Mossoff, would you like to just very briefly go over why the payer system we have in our country, if you have any information on how much that adds to the cost of healthcare in our country, I would appreciate your thoughts.
Thank you for the question, Senator. I don't have any specific data on the total costs of all of the different complex institutions, public and private, that exist in our healthcare system, except for the fact that I know generally as a scholar it is incredibly complex and it makes other systems look very simple and basic.
Yeah, and I think that if we really wanted to get control over the United States having the highest healthcare costs in the country, we should look at the payer systems that we have in place, but that's not what our focus is right now. It is clear that we do have abuses in the patent system, and I think it is important for us to very carefully target the abuses as opposed to passing legislation that is going to be overbroad. Would you say that some of the bills that we have passed out of this committee precisely target the abuses in the patent system? Anybody wants to weigh in on this? I think you're familiar with some of the bills that have emerged from this committee.
I think the bills are targeted effectively. The bills target citizen petitions. They target pay-for-delay settlements. There are very specific things that these bills go after that I think would undoubtedly improve some of the patent gamesmanship that we've seen. But I don't think these bills go far enough. I think there are numerous other targeted solutions that are simple and would help improve things.
Such as?
Such as have the FDA review every patent that gets submitted to the Orange Book. The FDA currently serves in a purely ministerial role. It doesn't look at the patents. The companies can submit whatever they want. So give the FDA the authority and the resources to review those patents. Force manufacturers, when they submit patents for listing in the Orange Book, submit them for re-examination to the USPTO. Very simple, but making sure that these patents that are listed in the Orange Book aren't being listed improperly.
Would the rest of you agree that those are some so-called simple changes where there's more collaboration, I suppose, information sharing between PTO and FTC, for example?
FDA and PTO, yeah, absolutely. I think that, and also Professor Dr. Feldman's point about the FDA's ministerial, so-called ministerial role could be fixed really readily and inexpensively if the FDA and PTO collaborated on every patent that was listed on the Orange Book to ensure that it's properly listed. This is a gap in the system that has existed for decades, and it's really unclear, to me at least, why this gap has not been filled.
Thank you for that suggestion. I have a question for Dr. Feldman. Last year, insulin prices were cut dramatically after surpassing the rate of inflation year after year. In a paper last year, you cataloged the, quote, the rise and fall of the insulin pricing bubble. I'm not talking about the situation where the legislation capped the insulin costs for Medicare. This has to do with insulin costs for everybody else. Can you give us some insight into why prices rose so high, why they fell so dramatically, and whether that experience points the way toward possible policy solutions we can use for other high, overpriced pharmaceuticals?
Thank you for the question, Senator. The reason why the prices of insulin rose so dramatically is because the three large insulin manufacturers obtained numerous patents to limit competition. They raised prices year after year, many times the original prices of these products. And the reason why prices came down so suddenly is that a rule in Medicaid lifted the cap on rebates, on penalties that these companies were going to have to pay. So previously it was capped at 100%, where if a patient used one of these old insulin products in Medicaid, because they had raised prices faster than rate of inflation year after year, they had to pay these very large penalties that were capped at 100%. They are no longer capped at 100%, and so insulin manufacturers responded by dropping their list prices.
So there are other ways that we can lower drug prices by, for example, impacting what PBMs are getting. Is that part of the approach that we should consider?
I think we absolutely should consider legislation that addresses PBMs. I think some of the things we've talked about here today, like spread pricing, the lack of transparency, all of these contribute to higher prices in the system. But I would say just on this question about insulin prices and why they came down so dramatically, it's a rule that forced manufacturers to pay penalties for raising list prices greater than the rate of inflation. And so I think with the IRA, we will see similar types of penalties moving forward. And I think, again, we need action with the pharmaceutical companies, and we also need action with PBMs.
Thank you. Thank you, Mr. Chairman.
Thank you, Mr. Chairman. With me today, Mr. Chairman, are two interns in my office, Ms. Anna Kate Luke and Quinn Eisenfeld. And I wanted to recognize them today. They're sitting behind me. Mr. Mitchell, I'm sorry about your health challenges. You made a very impassioned plea for us to consider the various bills that have come out of this committee. Why do you think the full Senate hasn't taken them up?
I think you've been busy with some other things.
You really think that's the reason?
Part of the reason, I think, yes, is that the Senate has been busy with many other things. I do think that there is an appetite on both sides of the aisle to advance these bills, maybe in the lame duck session.
Respectfully, I think you're wrong.
Tell me.
Okay. The majority leader controls the floor of the United States Senate. Whether that majority leader is a Republican or a Democrat, one person controls what the entire United States Senate can consider. And I don't mean to pick on Senator Schumer. He's my friend. He is exercising the power that we have ceded to him. If Republicans were in the majority, I feel pretty confident in saying that our majority leader, Senator McConnell, would exercise the same power. Do you think the Senate ought to establish a new rule that all senators are equal and some aren't more equal than others, and that if a senator can demonstrate that he or she has 60 votes to pass a bill, perhaps through the number of the co-sponsors, though that wouldn't be the only way, that senator should have the right to bring the bill to the floor of the United States Senate and allow senators in front of God and the country and their constituents to vote on it.
Senator, you're way over my pay grade.
Okay, you don't have an opinion on that?
No.
Professor, you're an attorney. Do you have an opinion? You don't want to make Senator Schumer mad? Is that your concern here?
That's an excellent question. It does seem to me that that level of control could be not optimal. The level of control exercised by one person.
You're a professor, right?
I am a professor.
Not optimal.
Correct.
Yeah. In the real world, we say it sucks. I came here today to learn, and I have learned a lot. But here's what I'm trying to understand. Professor, is your contention that because of the patent abuse, your words, not mine, that pharmaceutical drug companies are making obscene profits in the United States?
Thank you for the question, sir. I don't think it's obscene. I think that, as many people have pointed out, in the United States, we do fund research and development for the whole world, and that's a very, very knotty problem. So that's a challenge that I think we all need to take on. I do think that patent abuse contributes to lack of innovation, which might seem counterintuitive, but I'll tell you why.
Okay.
Because
let me stop you for a second, because I'm going to run out of time. You use the term patent abuse. You're obviously using it in a pejorative sense. Is this patent abuse illegal?
It is not currently illegal, but there are mechanisms that we could readily employ to curtail it.
If we passed a bill?
If we passed bills. There's also a lot that agencies can do right now using their current powers.
So why don't they?
They don't, because I think that Congress doesn't adequately push them to do it. So you need to hold oversight hearings, hauling up the FDA and the PTO, asking them why they don't cooperate more, including on the sort of thing that they can already do, which is exchange information, including trade secret information protected by trade secrecy law.
You think the problem is in part within our administrative agencies, like the FTC? Or
the FTC is, I think, doing a cleanup job on the back end, but the FTC can only work on the back end. Recall that the FTC's jurisdiction is antitrust. That's after all the bad stuff has already happened. They try to clean up on the back end. We need to nip the problem in the bud on the front end.
The FDA?
FDA can help, and the PTO can help.
Is the FDA doing a bad job with controlling patent abuse?
The FDA considers its role ministerial.
Are they doing a bad job, in your opinion? Come on, Professor, we're trying to find solutions here. Don't dance around on me. Tell me what you think.
I think they could do more.
Okay. I'm gone way over. Thanks for your indulgence, Mr. Chairman.
Thank you. I want to thank my colleagues for the work that you've done, and I do hope, Senator Kennedy, that we get those bills on the floor and have a chance to vote on them. You've done a lot of work on that, Senator Cornyn, and I'm very supportive of what you've done.
Well, I've suggested a way, Mr. Chairman, that we can get them on the floor. That I'm not trying to
talk to your friend, the majority leader.
I'm not trying to step on Senator Schumer's toes by any stretch.
Let's go back to the issue
both
here.
ways.
Thank you. You know, the bottom line here is the cost of health care in this country is killing folks. It is such a brutal, punitive burden on everyone, and that's for citizens in all of our states. Folks who are having trouble paying the rent, or they're having trouble paying for groceries. They can't even dream about owning a house. And when I was visiting with some employers in Vermont this week, they told me that the cost of a family plan for an employee is $40,000. That's $20 an hour, all right? And the biggest driver in healthcare costs are pharma costs, prescription drugs. And whether you want to call it abuse or gaming, the fact is people can't afford it, and it is not sustainable. And the reality, too, is that pharma's got a pretty sweet deal. It's got a guaranteed market with the Medicare, with Medicaid, with the VA. It's got employer-sponsored health care, and our employers in Vermont and around the country, they really care about having good health care for their employees. That's important to them. And then they've got the taxpayer-funded research, which is often the hardest, most risky research that the NIH does, that elemental research, as opposed to about marketing and what devices and how to package it. And then, of course, you've got the patent system that we're talking about today, where there needs to be reform, and there's been a lot of bipartisan effort here on this committee to do it. Let me just ask a few questions. Dr. Feldman, let's talk about Ozempic. Yeah, am I pronouncing that right?
Yes.
Yeah, what I understand is that you have done research a lot on this particular drug. And as we know, it costs $936 a month in the US, only $147 in Canada, and $83 in France. That's a huge expense for our employers and for our taxpayers. And last year, Novo Nordisk made $13.9 billion in sales from Ozempic, 60% coming from the U.S. So we're just paying an enormous amount. But on the patents, and you have researched this, I understand, there's 25 patents and only 4 are for an active ingredient. Can you just explain what that means?
Yes, that's exactly right. So over the years, Novo Nordisk has obtained enlisted in the Orange Book 25 patents on this drug.
And how many for the active ingredients?
And so 21 are on the delivery device. On the delivery device, the injector pen technology that is used for patients to self-administer the medication. The other 4 patents are non-device patents, 2 on the active ingredients and then 2 on methods of use or formulations. And so I think it's a perfect illustration of the problem. You have 25 patents, 21 on these delivery devices. The FTC has said these patents should never have been listed in the Orange Book in the first place. And you know, the brand name firms already are suing for infringement. They're litigating these patents.
Right. Okay, so I have a bill that I introduced with Senator Klobuchar and Senator Braun to streamline the drug patent litigation by limiting the number of terminally disclaimed patents a drug company can assert. In the U.S., the Patent Office, as you mentioned, Professor Rai, instituted a rule. But that legislation that would essentially limit that thicket, can you comment on your view on that legislation and how it would be helpful or not?
Yes, I think it's a great piece of legislation. The idea is that currently the Patent Office is required to reject patents that are obvious follow-ons from other patents, but companies can use these terminal disclaimers, which say, okay, the patent will expire at the same time as other patents.
Right, thank you.
And I think by limiting these litigation on these patents to one per family, I think it could promote
Thank you.
timely competition.
And Professor Ulrich, you know, I listened carefully to your testimony, and it's the same testimony I've been listening to for over a decade, and that is the sky is falling if we do anything that will interfere with the magic of pharma. But do you know how much the top 15 biggest drug companies reported in revenue in the first quarter of 2024? It was $173 billion. Does that sound about right?
I'm sorry, I don't have that figure in front of me.
Well, it's $173 billion. And of that, about 14%, $25 billion, was spent on research. By the way, that isn't specified as to whether it's for a new molecule or a combination of an active and ingredient or marketing. Novo brought in $9.5 billion in the first quarter and spent only $1.2 billion on R&D. Do you know how much Novo spent on shareholder dividends and buybacks? Yeah, $4.5 billion. So there is a question here with the advertising expenditures, with the shareholder buybacks and the dividends. Is there room for companies to consider maybe giving the consumers and the taxpayers a fairer price? Professor Wright, a recent study at the University of Texas focused on improving the patent approval process found that if the patent examiners were given more time to examine the secondary patent applications, it could save consumers up to $5 billion. Can you comment on that?
Absolutely. That study was conducted by a PhD scientist and a PhD economist, one of whom is a Duke, and it is an impeccable study. I think that it's bulletproof, and examiners need to be given more time. What that means, however, is that the Patent Office will have to raise fees because it is entirely fee-funded. I think that's a very wise use of the patent agency's fee-setting authority.
Thank you. Senator Cornyn.
Thank you, Mr. Chairman. Listening to the testimony today reminded me of a quote from H.L. Mencken, who said that for every complex problem, there's a solution that's simple, neat, and wrong. So that may be why I find myself agreeing with all of you, bits and pieces of what you say, but also disagreeing with all of you in other respects. But let me see if I can find some common ground here. So I'm a big believer in our patent system, and I believe the exclusivity that is provided to people who discover new life-saving drugs ought to be protected. But at the same time, I'm angry when I look at the abuse of the patent system by filing as many as 165 patents for something like Humira. And Dr. Feldman, when you mentioned that some of these patents have nothing to do with the active ingredients in the drug, but rather the delivery devices. In other words, you take a pill as opposed to something some aerosol you inhale or whatever, that this then prevents these incredible life-saving drugs from being more readily available and affordable to Americans. But at the same time, I recognize that if there wasn't the promise of a big financial payoff for the people that do this research, and I think somebody mentioned 12%, maybe Ms. Ulrich, maybe that was you, actual success rate. So that means that 88% of the drugs investigated actually fail, which is one reason why pharma spends so much money on R&D, hoping to hit gold, I guess, for that 12%. So I find myself sort of torn back and forth, and maybe that's the reason why we are where we are. But I do agree with Senator Kennedy. Senator Schumer could put these bills on the floor today if he wanted to. And Mr. Mitchell, you're being way too kind in terms of how busy you think we are here. We're working about 2.5 days a week and hardly breaking a sweat. So we have a lot more room to grow and capacity to deal with important problems like this. And taking up and passing bipartisan bills
it would be pretty remarkable. And it's in addition to the ones we've talked about here, the Finance Committee has done a lot of work, Ms. Ulrich, on the pharmacy benefit managers that you addressed. The 20-year patent system does not, there's a problem, I think, and you tell me if it's a problem, Ms. Ulrich. So you get 20 years exclusivity, but you may not have a full 20 years of exclusivity because you can't actually sell the drug until the FDA approves it. So there's a lag time frequently. And I think you said effectively the 20 years is 13 years. Is that correct?
Yes, for small molecule drugs, it's around 13 years on average.
I know that Hatch-Waxman many years ago tried to sort of figure out how to deal with that, but it strikes me as that may be some area where we ought to be able to give patent holders the effective use of their patents longer by making sure that the period of the exclusivity ran from the time that it actually was available to be sold as opposed to when it's patented. But that maybe is another discussion for another day. Mr. Mitchell, let me just say, I too wish you well. I'm glad we live in a country where you can get access to life-saving drugs. What I've always been told, though, is that the way that some of these countries, like in Europe, for example, that have national health care systems, deal with this is they restrict the formulary. That is, the drugs that are actually available. Do you know whether the drugs that you take that are saving your life would be available to you if you lived, for example, in Europe? My understanding is the EU only has about 40%.
I'd have to check country by country, but for the most part, the principal medications for myeloma are available abroad. Okay. I do think there's an important issue that you're touching on, and Professor Rice started to talk about it, and that is very important to me as someone who needs innovation. Patent abuse inhibits innovation. If drug companies can raise prices on old drugs that should have competition but don't, and they can raise them at will, then they have much less incentive to invest in the risky, innovative work that can produce new drugs that can extend life.
You and I are of one mind on that.
And so I don't want to just...
The chairman's going to cut me off because my time is up. Let me ask one last question. Does the fact that, according to the most recent figures I've seen, that 40% of the active ingredients in the drugs that Americans consume in this country come from China, does that concern you? After COVID, we became very concerned about supply chain vulnerability, and it strikes me that's a vulnerability. Is that not a problem, or is that a problem? Anybody have a view on that?
It is a problem, yes.
It seems like it. Yes. I would think so. And
indeed it is.
Maybe there'd be a way for us to do more of that.
Well, the FDA needs more resources.
Those active ingredients here in America. I'm sure it's a financial decision.
The FDA needs more resources.
Okay, thank you.
Senator Coons.
Thank you, Chairman Welch. And I am sorry that I had two other committee hearings at the same moment. I know this has been an important and robust conversation about a matter of great significance to all of us. I agree with my colleagues that we have to do more to reduce the very high price of prescription drugs in the United States. They remain too high for my own constituents. In fact, it's often the first thing I hear from in town halls. And I do think the Inflation Reduction Act has made dramatic progress in this direction. There's more yet to be done, and I'm hoping we can still get more done in this Congress. I do believe that there are other factors than patents at work in terms of high prescription drug prices. And as we've discussed, my core concern is that the patent system applies to a very wide range of products and goods, not just pharmaceuticals. And so what reforms or changes are made in order to pursue reduction in drug prices, I hope do not harm the foundation of the patent system that protects everything from roof shingles to batteries to electric vehicles to paint coatings. I mean, thousands and thousands of innovative products and services. So Let me, if I might, first just ask a question. Professor Mousoff, as I was leaving to the other hearing, you were talking about bi-dole march-in rights, and I don't get the sense that you've come back to that at all. The core issue I had with the direction that NIST went in allowing pricing for bi-dole march-in rights is it doesn't just apply to prescription drugs. It applies to everything. Mm-hmm. So any company who invents or any researcher who invents anything is now potentially open to the federal government saying, I want that, and I don't agree with the price you're setting for it. Is that accurate?
Yes, it's entirely accurate.
And are there breakthroughs in other sectors unrelated to pharmaceuticals or therapeutics or vaccines where you think having a price-based march-in right regime would put innovation at risk?
Oh, certainly. I think every sector of the innovation economy, from high tech to even areas in the manufacturing base, are threatened by this. It completely destabilizes patents as property rights when you cannot rely on this with certainty going forward, that the government won't step in at any particular point in time, decide arbitrarily you're charging too high of a price, and therefore interfere with your ability to contract in the market.
Is there compelling evidence that the highest priced prescription drugs or a majority of prescription drugs would actually have their prices brought down by having march-in rights available to the federal government?
Oh, thank you for that question, because that's an excellent question. And the actual studies show that actually a very few percentage of prescription drugs are actually covered by the Bayh-Dole Act. It's around approximately 1% is the last number that I saw. And so you would not see any effect in prescription drug prices with the adoption of this radical systemic change to the patent system, where you would have the ability of any government agency to march in and to dictate prices to the private market on any product and service.
One of the 5 bipartisan bills I think that is ready for action is one related to PBMs, Senator Grassley's Prescription Pricing for the People Act, which would provide transparency about anti-competitive practices by PBMs. I'd be interested in whether I missed a compelling conversation about PBMs and their role in the marketplace. Dr. Feldman, if you would, did the existing PBM structures make any sense in your view, and what role, if any, do they play in keeping prices unnaturally high for U.S. consumers?
Thank you for the question, Senator. The short answer to your question is they make no sense. I think that the current PBM structures make no sense. We have a system that rewards these high rebates, so high list prices, high rebates that ultimately affect out-of-pocket costs for patients. That for folks who don't have insurance, they don't have access to these rebates. You have spread pricing where PBMs are collecting more than they're actually charging the pharmacies, keeping the difference. So I think there are a lot of problems with PBMs. There's fundamentally a lack of transparency that makes it very hard for researchers like several of us up here to do our work, because we don't know what the actual prices of these drugs cost. So I think the bill out of your committee, there are several bills that address bad behavior from PBMs, I think are important. I will say PBMs are negotiating discounts, and so whatever legislation you all pursue, you don't want it to undermine the ability to get discounts. But I'm in full agreement. To go back to the very simple answer is it is not a functioning system.
It's a very complex multi-step system where the numbers of steps between innovation and manufacturing and price at the prescription counter has a whole series of steps. Last, I'm a co-sponsor of Senator Durbin's Interagency Patent Coordination and Improvement Act, and could not agree more that better communication between FDA and PTO can help improve patent examiners finding prior art. I agree with you, Professor. PTO needs to raise its fees in order to give examiners more time to do a more thorough job. Patent quality is something I would hope we all agree on. I'd just be interested in whether you think there's either other agencies the PTO director ought to be coordinating with, or there's more we could do to improve collaboration between the PTO and the FDA, and I recognize I'm over my time.
So yes to everything you're saying, and there's a laundry list of other agencies that the PTO could collaborate with, but since we're focused on drug pricing, I think FDA is the most important one.
Thank you. Thank you for this hearing.
Thank you. Thank you very much. Senator Ossoff.
Thank you, Mr. Chairman, and thank you to our panelists for joining us today, and Professor Mossoff. We should perhaps determine whether we're distant cousins. I am grateful to you all for your expertise. Dr. Feldman, I want to discuss with you the prices that Georgians are paying for inhalers, children on Medicaid, seniors on Medicare, and everybody in between. First, I just want to note generally, the prices that Georgians are paying for prescriptions are outrageous. The stories that come to me in my office are shocking. From a constituent who right now is having difficulty making ends meet and affording cancer treatment, who watched their own friend die from being unable to afford cancer treatment, a veteran in Georgia who right now is having to scrape together thousands of dollars per month in order to afford leukemia treatment, kids and seniors with asthma or COPD who are having to pay exorbitant prices for inhalers, medical devices across the board, and the tremendous lobbying power of the pharmaceutical industry is a major driver of the outrageous prices that Americans pay. And of course, there's a balance that we have to strike between making sure that research and development and innovation are rewarded and the interests of patients and consumers, but this country is not getting the balance right. We made big progress capping the cost of insulin for seniors on Medicare Part D at $35 a month, finally empowering Medicare to undertake some negotiation with pharma over prices, but we have a long way to go. And let's talk for a moment, Dr. Feldman, about inhalers. And I know that some voluntary caps are now in place, but Medicare, Medicaid, still not participating in that. You've seen countless patients. You're a pulmonologist, correct?
That's right.
And so you've seen countless patients dealing with serious life-threatening asthma and COPD, is that right?
That's correct.
How long have inhalers been on the market?
The first metered dose inhaler was approved by the FDA in 1956.
1956. In the last few decades, have the active ingredients in these devices substantially changed?
No. Since 1986, there have been no inhalers for asthma or COPD with a new mechanism of action. That means of the dozens upon dozens of brand name inhalers that have been approved, not a single one has an active ingredient that is fundamentally different from other active ingredients in the same class.
For 3.5 decades, you're saying the active ingredients have been basically the same.
That's right. Some tweaks to the molecules where you get new active ingredients, but in the same class. And so fundamentally, no major breakthroughs in terms of managing these diseases from inhalers.
So why are so many Georgians and so many Americans still paying hundreds of dollars for these devices?
I think it comes back to really what we're focused on in this hearing today, which is these problematic patenting practices, product hops, where companies are taking decades-old active ingredients, getting patent protection for the delivery devices, for other aspects of the products, and it allows them to keep prices high by limiting generic competition.
So product hopping or device hopping, just for folks tuned in from Georgia, define that in a nutshell.
That's where you take the same ingredient or set of ingredients and put them from an old delivery device into a new delivery device that may be no better than the earlier one, but it does have new patents. So it allows you to move people from an old device to a new device. If you're a brand name company, earn a lot more revenue by doing so, but to no benefit for patients.
And so that patent based upon no innovation of the underlying medicine, some nominal innovation of a device, then boxes out competitors, generics, and helps keep prices high, right?
That's exactly right.
Now, I do want to note some manufacturers have agreed to cap out-of-pocket costs for inhalers. Does that apply to Medicaid or Medicare?
It does not. Those caps do not apply to Medicare and Medicaid.
So for a kid on Peach Care in Georgia, for a senior, and I think, according to my notes here, 1 in 9 Medicare beneficiaries have COPD. Those caps don't apply.
That's correct.
Where else do we see this practice of device hopping or product hopping?
We see it really for all drug device combinations. What are drug device combinations? Those include products like insulin pens, inhalers, EpiPens, GLP-1 receptor agonists that Senator Welch was asking about. So it seems like kind of a niche set of products, but in fact, if you look at the top 50 drugs by Medicare spending in 2022 by gross spending, 40% are actually drug device combinations.
Yeah, just about every family in Georgia has had to think at some point about, do I need to carry around an EpiPen for my child who has an allergy? Do I need to purchase an inhaler for my child with asthma or for a grandparent suffering from COPD? And yet these abusive practices, where there's not innovation on the underlying drug, but there's some nominal change in the product, is boxing out competition and keeping prices high. And this is, Mr. Chairman, a place where I hope we can achieve some bipartisan consensus to make progress for Georgians who are struggling for these basic medical products. Thank you, Dr. Feldman.
Thank you.
Senator Butler.
Thank you so much, Chairman, and thank you to all of you for coming. It's an incredibly important issue for Americans all over the country, particularly for folks living in my state, and so I appreciate all of the work that you all are doing here. A couple questions, just really quickly. I think I want to direct this question, if it's okay, to you, Dr. Feldman. Across our country, many families are choosing now between putting food on the table and purchasing those life-saving healthcare drugs and medication, all the things that we have been talking about throughout today's hearing, paying nearly 3 times as much on prescription drugs compared to families in peer countries. Dr. Feldman, as a physician, how have you seen high prescription drug costs not only impact patients, but affect the livelihood and financial stability of the full family?
Thank you for that question. I have. You know, we often think about, as physicians, how these high out-of-pocket costs affect that patient. Are they going to take the medication? I spend a lot of my time when I'm practicing, I work in the medical intensive care unit. We admitted a patient recently who had diabetes and was there with DKA, diabetic ketoacidosis, which can be a fatal complication of not taking your insulin. When I asked her what happened, she said, I just couldn't afford my insulin. And I think as physicians, we're laser focused on the problems for the patient, but there is no question that every dollar that is spent on those high out-of-pocket costs for patients mean $1 less that they can spend on getting food, clothing for their kids, for their loved ones. So I think it's an important point that we probably don't think enough about.
I appreciate you acknowledging it. You're right. There's lots of conversation among practitioners about the patient complying with the medication orders and managing their health and the unintended consequences that making those choices have across the full family, then also potentially lead to the young person not being able to sort of have the resources to meet their sort of full impact in life. So I appreciate you talking about, are there particular populations that you think that are disproportionately touched by these kinds of financial burdens, just in the patient population that you've seen or experienced that we need to be thinking about specifically?
All of the issues that we're talking about today have disproportionate effects on the most disadvantaged members of our society. Where do we see the highest rates of asthma, of COPD, of diabetes? It's in already disadvantaged groups of patients. And I think a big motivation for my work is trying to address these problems to resolve some of these disparities. I think we've talked a lot about different proposals. It can feel very lofty, a lot of these conversations we're having about the patent system. At the end of the day, we're talking about expensive medications for people who can't afford them, and it disproportionately hurting certain members of our society in ways that I think are problematic.
And this is a line of questioning that I wanted to get to, because I do think that there's a lot of complexity, as was noted in the first witnesses' offerings. There's a lot of complexity to the systems and the laws as we're and consequences, intentional and unintentional, around the bureaucracy, and so often we can lose sight of the people as we try to navigate the morass of the process. And so I wanted to make sure that for those who are taking, an hour to watch C-SPAN, whose issue, but whose lives are very much impacted by the cost of medication, that we give them an opportunity to remind ourselves that at the end of the day, this is about the American people as opposed to the complexity of the process. And so if there was one patient that you could offer their story for consideration, I'd love to give you my last 10 seconds to talk about and offer that one story.
Yeah, I'm thinking about a patient that I saw when I was a fellow in pulmonary medicine, and it's hard to talk about costs with patients. A lot of patients are embarrassed. People don't want to talk about the fact that they can't afford their medications, but I remember talking with her, and she, rather than using inhalers, which are more convenient, which she could not afford, she was using cobbling together therapies via nebulizer, which is not something we've talked about, but it's basically where the ingredients are sold separately, and they can work, but her story sticks out in my mind because, number one, it was hard for her to talk about. Number two, she couldn't use the medications that we prescribed. She had to use a medication that takes longer to administer. You have to do it at home, and it's exactly like I was saying before. The most disadvantaged members of society are the ones who are affected by these patent games. I think if we want to address racial disparities, socioeconomic disparities, we have a lot to do in this country. But everything we're talking about here today is a way of doing that.
Thank you, Mr. Chair.
Senator Klobuchar.
Thank you very much, Mr. Chair, and thank you for the work that we've done together on the negotiation Medicare prices. We're so pleased. I was hearing you talk, Mr. Mitchell, about Eliquis, one of the drugs, as you know, that's now being negotiated of the 10 blockbusters, with many more to come. I want to start, though, with one of the issues at a bill that still hasn't passed that Senator Grassley and I have been working on for a really long time, which I know he mentioned, pay for delay. And as you know, Mr. Mitchell, anti-competitive pay for delay settlements, where a branded pharma company pays off a generic or biosimilar company to delay the introduction of the competing drug product, is sadly a common practice. Our bill, it's called Preserve Access to Affordable Generics and Biosimilars Act, strikes a balance between targeting anti-competitive settlements while allowing pro-competitive patent settlements to proceed, and saving an estimated $1.6 billion over 10 years. Mr. Mitchell, you mentioned the drug that you depend on, Revlimid, which that was caught up in a pay-for-delay settlement, as I understand. How did that affect the cost of the drug for you personally? How do pay-for-delay deals keep the cost of prescription drugs high for patients generally?
I took Revlimid for 5.5 years, and during the time I took the drug, both the underlying price, and my out-of-pocket rose dramatically. By the way, Revlimid was the second most expensive drug for Medicare until it began to have competition last year to treat only 39,000 patients, the second most expensive drug for Medicare at $5.4 billion. When the drug company that owns the patent decided to let competition come on the market, it limited the generics to a lower market share, 10% each for the first two competitors. If you have a limited market share as part of the deal, you will not lower your price because you cannot gain market share. What happens then is the brand drug company and the two generics, in the case of Revlimid, shared the monopoly and the price didn't come down. This is a pay-for-delay deal. This is making an arrangement to say we won't fight you in court. Instead, we'll give you a market share limited deal, and you will make a whole lot of money for a few years while we delay real competition.
Very, very good description. Thank you. Turning to another issue that has been discussed today, that's sham FDA petitions. Dr. Feldman, this practice risks delaying the approval of generic drugs and biosimilars, imposes unnecessary burdens on FDA resources to add to everything else when they have so much to do. Senator Grassley again and I introduced a bill, the Stop Stalling Act, to give the FTC enhanced authority to crack down on abuses of this process while allowing petitions submitted in good faith to raise legitimate health and safety concerns. CBO estimates that the bill would save taxpayers $400 million over 10 years. As you know, both of these bills have gone through this committee on a voice vote. Which types of entities filed the majority of citizen petitions challenging FDA approval of generic or biosimilars, Dr. Feldman?
Brand name drug companies.
Mm-hmm. Okay, and can you elaborate on the harms to patients and competition caused when pharma companies use a citizen petition process to delay entry of competing drugs? I just find it ironic indeed when it's a citizen petition process and the citizens are getting screwed by it, but continue on.
I have felt that same irony myself. So first of all, we should say that companies are doing this because every day of delay for some of these blockbuster drugs can be worth millions or tens of millions of dollars for the companies. So there's a strong incentive to do this. And basically what happens is the brand name firms will wait until the right moment to put a question to the FDA to request that they not approve a generic medication. And it slows things down. And every day that we slow things down is more revenue for the brand name manufacturers, but it's one less day that patients get access to generic drugs. And we know that generic drugs are the number one way to lower prices in this country. It is a way to bring down costs for patients. So I think it's a good bill. And as you said, these are not citizen petitions. They are put out there by the companies for economic gain.
Mm-hmm. Last, Professor Rai, the price of 25 brand name medications that Medicare spends the most on, some of which are negotiated, of course, right now or in negotiations, have on average tripled in price since they hit the market. You have written that Medicare price negotiations will promote the entry of new drugs by reducing the incentives for brand drug companies to engage in anti-competitive patent strategies that can allow for these price increases. So this is kind of where our Medicare negotiations, that is almost a outcome of all of this bad activity, sort of hits the road and combines with this patent problem. How will requiring drug companies to negotiate prices with Medicare, as I said, with more on the road, despite lawsuits going on right now all over the country to try to stop us, which seems unbelievable to me given that Congress is the one that made the deal and Congress can change a deal. How will requiring drug companies to negotiate prices with Medicare deter pharma companies from playing patent life cycle games to preserve high prices and facilitate entry of competitors and further reduce prices?
So I think the Inflation Reduction Act is one of the most important patent reforms of the 21st century. And the reason is this: it finally places a time limit, at least for Medicare, on how long you can extend an old drug, which means that you have to come up with new drugs, truly new drugs. And that is a game changer, it seems to me. Now, I wish it was only more than 10 drugs, and it is increasing, fortunately, but I think that's how it spurs innovation, and Dr. Feldman noted this as well, or Mr. Mitchell noted this point as well, that it spurs innovation to prevent patent abuse.
Mm-hmm. Very good. Thank you. And I'll turn it back to the chair.
Thank you. Thank you very much, Senator Klobuchar. Senator Tillis.
Thank you, Mr. Chairman, and I apologize for not being here sooner. I am under the weather. I have tested. I do not have COVID, but I've wanted to make sure the room was cleared before I came in to speak. But this is clearly a hearing I needed to come to based on the work that we do on the Intellectual Property Subcommittee. I have been watching the hearing. I want to associate myself with the comments from my chair and colleague on the Intellectual Property Subcommittee, Senator Coons. I am a really boring person because I really try to do my best to not be sensational, to be fact-based, to drive my decisions. It's one of the reasons why I'm shocked that I've actually won the elections that I've run, because I tend to want to get into the nitty-gritty details. So I'm only going to spend a few minutes, and then hopefully, you need to get that? Kidding. He's my staff. I want to talk, number one, the Inflation Reduction Act was heralded as a great thing. There are actually some good things in the Inflation Reduction Act. I don't necessarily hear a lot of people lauding the fact that we've had a double-digit reduction in small molecule research, and we've actually even had board meetings where investors have been told we're de-emphasizing this. Does anybody disagree that the Inflation Reduction Act, the decisions in there around drug pricing, does anybody think that there isn't a nexus between that and the reduction in small molecule research? And of course, I'm going to first go to the person who's from North Carolina here. Professor.
So thank you for that question. I'm so glad you followed on from Senator Klobuchar on that question. I believe that small molecules need greater incentives, and the way to do that is to establish parity between small molecules.
I understand that, but
I'm
getting to the fundamental question. Do you agree or disagree that there appears to be a nexus between the well-intentioned drug pricing policies in the Inflation Reduction Act and a reduction in investment in small molecules?
So I have no idea why the IRA limited small molecules
Mossoff,
to 9 years versus 13 years for biologics.
I think it makes complete sense that if you impose what is essentially effectively a price control system on the sale of drugs, that price controls destroy and undermine markets. This is well established.
Can I ask you more, Ms. Ulrich? We saw drug prices listed here, and they're unacceptably high. But is that a drug price that was set by the pharmaceutical company, or is that what happens through the sausage meal value chain that starts with an investigational, a promising compound, an investigational new drug, clinical trial monitoring, manufacturing, pharmacy benefit managers, insurance companies, doctors, and a patient? Which one of those is true? A big bad pharmaceutical company sets a price, or that whole sausage factory occurs before you know what the price is?
Well, thank you, Senator Tillis. We would agree that there is a large sausage-making process, but largely
so if you want the sausage to taste differently, you got to have all the components in the value chain at the table, right?
That's right.
So how on earth can we give a pass to the pharmacy benefit managers when we're taking a look at the end price of a drug and try to figure out why it costs what it cost, right? Now, the other thing, and Mr. Mitchell, I wish you the very best. I have, you've got a more aggressive disease, but I too have an incurable, potentially fatal disease that I don't have to manage with drugs now, but I understand a modicum of what you're going through, and I'm sure it must be challenging for you and your family. But I do believe that there was a point made here that's very important. The price of that drug through your health care system that's not available on a formulary in other countries is zero, and the reason for that is because you can't get the drug. Now, I know you answered that question that there are certain jurisdictions where you do have access to it, but there are some where you don't. Again, trying to get back to the facts, folks, we can't say we want to be just like fill-in-the-blank country if fill-in-the-blank country doesn't give you that an option through their single-payer health system.
I think
then you come here.
Senator Tillis, to remember that we use formularies in this country.
Yep.
Most employer-provided plans use formularies. The VA uses a formulary.
I agree. I'm getting more to the fact, I think we're being simplistic when we say we want to be just like fill in the blank. If we want to be just like fill in the blank, then let's have our litigation systems just like other countries. Let's have medical malpractice policies very similar. There are so many things that make us dissimilar that we've just got to be realistic about how far we're willing to go. But more importantly, I've been here for 10 years. The substance of this hearing is not materially different than the substance of hearings that I had in my first Congress here. So why is it? You all make great points, and I agree with a lot of what you say. I agree with qualifications on other ones. I wanted to talk about the IMAC, for example. Professor Mossop. I'm not going to go too far over my time. I know I'm extending the hearing. But just getting data from the IMAC to a point. I'm trying to get the U.S. PTO and the FDA just to take that information, distill it into something meaningful, because I believe today, and Professor, I think we may disagree, that people are using it conveniently to build their case. But look, folks, I've been here for 10 years now. We're not making progress. If anything, we've taken steps back because of well-intentioned provisions in the Inflation Reduction Act. We at least know that we are reducing incentives to invest and take risk. The majority of these projects, I was in the tech space, so we knew that when we made I was in research and development. So we knew that the majority of the ones that we're going forward with were going to be successful. It was just a technological change for products that we were going to make commercially available. Some of these things are billion-dollar investments that get put on ice after a while. I'm thinking about the much-publicized Alzheimer's drug. I don't want to reduce innovation in this country because people's lives are in a balance. Potentially a cure for the disease that you're going through, a cure for the disease that I'm challenged with. And so I feel very, very strongly that we need to stop talking past each other, finding one link in the value chain that we naively think is the way you solve this problem, and all agree that there are ways to increase availability and decrease the cost of prescription drugs, but it's not the simplistic approach to take in only one link in the chain at a time. And I would love, Mr. Chair, to find a damn drug that I could put up there that everybody is demonizing and start from the beginning, the entire investment, the whole history of the patent protection for that drug, the end user price, so that we could really start getting past these lovely discussions we have once a Congress, maybe twice a Congress, and into something meaningful that helps the patient, who is the only person I care about. How we can save more of you, how we can do it on a more affordable basis, and we've got to start getting people to stop talking past each other to get it done. Or, Mr. Chair, I look forward to the next Congress having a hearing that's substantially the same information with substantially no progress. We've only taken steps back in the 10 years that I've been here. We haven't really made major leaps forward. Thank you, Mr. Chair.
Thank you. Senator Booker.
I want to thank the panelists for being here today. I really appreciated your testimony and the common sense input that you had. Mr. Mitchell, I was really moved by your testimony. Frankly, because it's testimony I hear all the time, everywhere I go. About half of Americans take at least one prescription drug. For seniors, it's upwards of 80% of seniors are taking a prescription drug. And it is outrageous that about a quarter of Americans really have a difficult time affording those drugs, often for critical life-saving needs. I am stunned that we live in a world where the same drug can be sold, 2 to 4 times higher. That means Americans are often paying 4 times as much. And it is stunning when I hear people telling me what they do to cope. They delay refills. They ration their drugs. They are just foregoing taking the drugs. And this is what's fascinating to me is most people don't understand. This often creates higher costs within our system. When a diabetic goes into diabetic shock, I know what that's like as being a mayor, having a lot of my people end up in hospital emergency rooms because they were reducing their they're rationing their insulin drug costs and ending up in hospital emergency room, driving up the costs of our healthcare system. It is so outrageous to live in a nation that is the wealthiest nation on the planet Earth and have so many Americans suffering daily, making the most difficult decisions between paying rent, kids' tuition, food on the table, or taking their prescription drug. Now, I disagree with my colleague because we've actually done some good things. The Biden administration has allowed Medicare to be able to negotiate prices for the first time. Insulin, I was just down in South Carolina getting wild applause when we reminded people that the president and this Congress have capped insulin costs at $35 for people on Medicare. And for me, I was talking to a predominantly African-American audience, blacks are twice as likely than white Americans to forgo taking a prescription drug that they need. And next year, out-of-pocket costs for Medicare Part D will be capped at $2,000. So I don't think we're wasting our time here, but I'm very frustrated to see how much lobbying money comes down here to try to stop us from doing things that are common sense. We can balance being the innovation capital of the world and having affordable prescription drugs for Americans. These are not counter. But right now, I see games being played, gross profits being made because people are working the system. This is why I've introduced legislation that I've written, co-written. I've joined colleagues. We're about to reintroduce the Prescription Drug Affordability and Access Act in the coming months. Last Congress, I joined Senator Sanders and Senator Casey to introduce the Affordable and Safe Prescription Drug Importation Act. I'm proud to have joined my colleagues on this committee, Senators Grassley and Klobuchar, on their Preserve Access to Affordable Generics and Biometrics Act and the Stop Stalling Act. These are common sense pieces of legislation that can make an extraordinarily big difference. I cannot tell you, Mr. Mitchell, how frustratingly common it is for me to be grabbed by somebody when I'm out and about in multiple states for them to tell me their stories. When I ran for president, I had people bring to me their bills to show me what they were paying out of pocket. And then, I'll never forget in New Hampshire, the same person showing me their salary and explaining to me why they're putting their health in danger every single month because it does not add up. And so, Mr. Chairman, I know I'm spending more of my time speaking now, but when I read the testimonies and listened to some of the testimonies today, there are just common sense things that we could do to relieve this pressure, to save lives, to keep people out of emergency rooms, to keep families together and healthy. I just want to say for the conclusion, the question, Ms. Rye, and I'm pronouncing that right, Rye, I thought I had it right.
You got it right, yeah.
Thank you, Ms. Rye.
Huh?
I really think that the President Biden is being an extraordinary actor in this space. And they're in the process, the Biden administration is finalizing a proposed framework for exercising march-in rights on government-funded inventions, including prescription drugs that are priced out of reach for patients, despite having been invented at public universities with public money, federal grants, taxpayer dollars. And that's the thing that often frustrates me the most, is taxpayers are investing in these inventions and then they're paying, they get no discount, they get no VIG because of our country, but then they look at other nations and these drugs that we invented with our taxpayer dollars are so much lower. So I just want to hear your thoughts on this framework and on the prospect of the Biden administration using these rights to license generic competition on drugs that are priced 2 or 3 times or more than prices on drug corporations charge in our peer nations.
So I'm glad you asked that question. Thank you, Senator Booker. I think the NIST guidance is actually much more careful and modest than some of the critics would have it be. It's very carefully designed to target situations of price gouging, essentially, not the situations that have been discussed earlier where, you know, for example, you need recoupment of your R&D costs for something legitimate, but rather situations of the sort where there is price gouging going on. And the NIST guidance is very careful to say price is a factor and to consider. And agencies, just to be clear, have never used march-in rights. They've had march-in rights from the beginning. NIST has had march-in rights from the beginning, never been used. This is just a gentle nudge to suggest that sometimes, just sometimes, price could be a factor.
Thank you. And I'm just going to say, because there's an elephant in this room that we have not talked about, politicians, senators, and congresspeople should not be taking campaign contributions from industries that we are regulating. It just shouldn't. I think I was the 4th senator saying no corporate PAC dollars, no pharma C-suite money, no oil company money. I really think there's a problem in this institution with corporations coming here and throwing millions, if not hundreds of millions of dollars into campaign war chests, and Citizens United, which allows dark money to be spent without any accountability or transparency. To not think that this is a major part of this problem and that we should pass laws to prevent that, or everyone should take a similar pledge, I really think that is an inhibitor to solving problems that have so frustrated Americans for so long and that seem to have such, as some of the commentary here, such obvious solutions to drive down prices. Mr. Chairman, thank you for the latitude.
Thank you, Senator Booker. I want to thank the witnesses. You know, one of the extraordinary opportunities you have in this job is to hear from people like you who have spent your careers studying things that are hard to learn about, and you share that information with us, and hopefully it'll result in some action. But I just want to express my gratitude to each of you for the commitment you've made in your lives to really public service research and work. The hearing record will remain open for 1 week for statements to be submitted to the record, and questions for the record may be submitted by senators by 5 p.m. on Tuesday, May 28. Thank you all very much, and the hearing is adjourned.